My name is Courtney Cuthbertson. I'm a postdoctoral fellow with the Community Assessment and Education to Promote Behavioral Health Planning and Evaluation, or CAPE project, which is sponsored by the Substance Abuse and Mental Health Services Administration, as well as the United States Department of Agriculture's National Institute of Food and Agriculture. We are recording this webinar, and it will be posted on the healthbench.info website after the webinar has concluded. I'm very pleased to introduce to you today Stephen Clearer and Shante Jett, who are joining us today from Oregon to talk about their work with software-assisted medicine. If you have any questions for Stephen or Shante as they're speaking, please feel free to type those questions in the chat box on the left, and Stephen and Shante, you can either answer the questions as we go or take them at the end of the session today. So without further ado, I'll hand it over to you.
So this all came out of the fact that we are in a state that is very unique and perhaps a little bit interesting. So Oregon is a very diverse state, as many of you probably know. We have a multitude of geography and landscapes, moving from the coast into the mountain regions in central Oregon, and then moving to high desert over in eastern Oregon. Actually, most of our state, about a quarter of our state, is actually high desert. We also have a very wide range of cultural diversity. We have very urban areas such as the Portland metropolitan area, which has fairly significant percentages of minority populations, fairly heavy on the Hispanic and Asian, particularly Vietnamese populations. And then we have our rural areas. This actually happens to be a picture of my hometown, which is very rural and very different from the urban areas of Oregon. Approximately 70% of the population of the state of Oregon lives within within 15 miles of Interstate 5, which is the major freeway that goes north and south about 1/3 of the way into Oregon. And then the rest of the population is spread out over the rest of the state, which creates some unique changes and challenges. One of the things that Oregon has also been known for over the years is an attempt to be fairly innovative. And one of the things that recently Oregon has jumped on is innovation in healthcare. And our governor, who happens to be a family physician, picked this up as a very important part of his agenda, and a couple of senators at the state level jumped on this, and so we ended up with a very robust healthcare reform initiative that was developed by the state of Oregon. And this is all based around what is called coordinated care organizations, which are community-based and governed organizations that are a hybrid of a health plan, like an MCO, and an accountable care organization. It is a merging together of medical, primary health care, behavioral health, dental health care, public health, social services, housing, pretty much everything lumped into one system. The CCOs themselves are networks of health providers. I'm not going to go into the whole CCO concept a lot, but I wanted to set the scene for kind of how we got to where we got in our whole process. The CCO concept was approved by the Medicare, Medicaid people at the federal level. They gave us some flexibility to do things innovatively. They also gave us a little bit of extra money. And in return, we said that we would create a 2% reduction in per capita Medicaid expenditures over a period of time, that we would not reduce benefits and eligibility in order to meet those targets, the reduction in cost, that we would measure outcomes effectively and prove that we were doing a more effective job, and that we would develop a workforce that was different from the workforce that we were currently using. And the primary change that was going to happen there was going to be the inclusion of community health workers and behaviorists in the primary health care clinics. The idea was to develop a system that is 100% integrated care, which would look at the person not only from just the physical perspective or even the mental health perspective, but would also look at transportation and housing, employment, financial security, nutrition, education, the whole mix. So these are the current coordinated care organizations as they have played out in the state of Oregon. And our CCO, which is Eastern Oregon Coordinated Care Organization, is the orange section that you see. And we are the county that's in the far upper right-hand corner of the map of the state of Oregon. It's Wallowa County, and that is where we live and do our work. Wallowa County is a remote frontier county. We have a population of 7,000 people in the county, a population density of 2.3 people per square mile. We have 3 primary healthcare clinics. We have 1 critical access hospital, 2 pharmacies, and then the Wallowa Valley Center for Wellness, which is our program, which is a mental health and addiction program, and also includes developmental disabilities. As a result of the initiative that the state has put together, our county decided that we were going to be proactive in terms of responding to all of this. Some of you may appreciate how things started at the state level and moved down. We were a little bit spooked by the concept of trickle-down healthcare reform, because often when the state decides to do things and jumps on the bandwagon, they start defining how it's going to look, and how it's going to look from their perspective does not always work very well in rural areas. And so our goal as a group of providers in our county was to say, we're going to define what it's going to look like at the rural level, at the frontier level. We're going to show how it can work at the frontier level and try to do that before the state got all kinds of great ideas and started dictating to us how we were going to have to do it. And so we created the Wallowa County Network of Care, which was created in order to develop a functional response to this whole concept of healthcare reform and integration that was coming down from the state. The group, which meets monthly, includes providers such as MDs, nurse practitioners, RNs. It includes a mental health program. It includes physical therapists, pharmacists, chiropractors, functional medicine practitioners, the programs, the community partners that deal with transportation and housing and education and domestic violence. It's a very, very, very diverse group. And what this group wanted to do was create a network of care where people could access care in our county and really have this whole concept of integration taken seriously, but also have the concept of working with people holistically taken seriously. And so when the group developed its kind of vision for itself, one of the things that they came up with was the mission of 100% access and 0% disparity. We wanted people to come in, be able to get in with no barriers, and be able to get full spectrum care, kind of no matter what their insurance was like, no matter what their situation was like, no matter what their issue was. And so the initial projects that the group started working on was, one, tearing down the silos. So instead of there just being mental health or being primary care, we wanted to try and think about the clients more holistically and focus on a full spectrum of domains of health. Second thing we wanted to work on was access and referral. We wanted people to be able to get into care effectively and quickly, but we also wanted to be able to make sure they were connected with all of the services that they needed, and that's where referral came in. Our sense was that people would come in, we would understand that there were other issues, but we would refer them, or we would suggest they go to this agency or that agency, or another agency would suggest they come to us in mental health. But the problem is that those connections weren't happening. The referrals were not efficient and effective, and so we wanted to address that issue. And then we also wanted to look at creating standardized responses to complex and persistent health issues. So part of the reason we wanted to get together was to say, what do we do as a system if we have an issue within our community that we're trying to address, but it doesn't seem to be getting better. So if we have a whole lot of people with back pain, or a whole lot of people with addiction issues, or a whole lot of people with any particular issue, and we can see that as a county we are having we're not having good outcomes with that particular population or that particular issue, what's not working? And try to work together to create answers, which might involve some non-traditional approaches to that issue, so that issue gets dealt with. We also wanted to look at hotspotting. Obviously, since we're trying to cut costs, we wanted to look at those people who were spending the most money on. Is that necessary? Are there things that we could do differently so that those people aren't in the ER as often, so they're not in the hospital, so that we can keep them at a lower level of care? And then finally, the group said, of course, the only way we're really ultimately going to be able to change the way that our community works is by prevention. We've got to start putting more effort into prevention, working with children, working with parents, working with everybody on preventing people from getting to the more difficult levels in terms of their healthcare issues. And so that was where we started. One of the first things that we did is try to really develop integration with primary care. And I'm talking here mental health, drug and addiction, and primary care all integrating and working together. And so one of the things that we did was we trained some of our master's level therapists, 3 of us, as behaviorists or health coaches. We used the University of Massachusetts online training with Sandy Blount. We rented a suite of offices in a new medical office building right next to the hospital, right next to a primary health care clinic. This particular clinic serves about 70% of the clients that we see in mental health. And so we now have a suite of offices right next door. There's an open door between our 2 clinics, and our behaviorist room is actually in the mental health side, but is right next to the medical clinic. And then we embedded our behaviorists in the primary health care clinic 5 days per week. And so the behaviorist doesn't sit in a room over on the mental health side, but actually sits in the pod on the primary health care side with the primary health care team, considered a part of the team, and is available for warm handoffs constantly throughout the day. And then also has the behaviorists also have clients scheduled about half the time that they're in the room. So what we have to start with is this model of care. So a patient comes in, let's say to the primary health care clinic, and sees the primary care provider and then maybe the behaviorist. And at that point, a variety of options begin to unfold. One, the healthcare coach, the health coach, works with the client on behavioral issues related to health, but they stay pretty much within the primary health care system. But the issues are primarily behavioral, and so we're working with high blood pressure, we're working with weight loss, we're working with diabetes and those kinds of things. Second issue could be that we work with those things, but we also recognize that there are some mental health issues present, but they're fairly moderate. They can be dealt with brief interventions, with a little bit of skill training, with some medication management. So those clients are also kept in the primary health care system primarily, with a little bit of help from the behaviorist and the mental health system as necessary. And then the third thing that can happen is we start working with the person around behavioral health issues and what we thought were maybe some fairly minor mental health issues, and we realize as we go along with this person that, there's some significant things going on here. This person could really use some specialty mental health care, and so at that point they are referred over to the mental health program for specialty mental health care. So those are kind of the 3 options. So we have kind of three areas: strictly primary care with a little bit of mental health, which is kind of a middle bridge. Maybe primary health care would be a way to think about that. Primary mental health care would be a way to think about that area. And then we have the specialty mental health approach, which comes in. So we started to do that with Winding Waters Clinic, which is our biggest clinic. We have made ourselves available to the other 2 clinics, but they haven't jumped on board as strongly. Then we've started to work with everybody, including the clinics and the community partners, on community projects. And those have involved things like mental health first aid, participating in a community health worker hub, working with a childhood obesity program called Fit Fridays. It was funded by the CCO, which gives the grants for local projects, which is just starting up in the near future. So we're working within the clinics, we're working within the community, we're doing all of these things. But the thing that we've really wanted to focus on again was this holistic care, which was taking into account everything that impacts the person's health, and that is where the whole SAM program really comes in. And in order to talk about SAM and the domains and how that whole process works and what we're doing with that, I'm going to turn it over to Shantae because she's been the person that has really been working and has really been helping set this up with our community partners.
So initially, when we were thinking about how to fill the gaps in terms of accessing care for folks, we decided at a local community advisory council to ask the people who access services what we do well in the county and what we could improve on. On a whiteboard, we put up 14 or 15 different domains of health, and folks came up to the whiteboard and listed under each domain what we do well and what they would like to see done differently. From there, we created what we call the domains of health, which is a questionnaire. And initially, we didn't know about SAM, and we were building this platform through a Google process. And right in the middle of that, we were contacted by the CGM group, who also works with Greater Oregon Behavioral Health, which is our behavioral health side of our CCO, and asked if we might be interested in piloting software-assisted medicine. SAM is a web-based disease management platform that's used all over the world, really, mostly in Europe, by payers, accountable and coordinated care organizations, providers, and patients to do the same thing that we want to do here: improve healthcare quality, lower costs, and ultimately save lives. We find that it's a very adaptable, state-of-the-art platform that we've been able to work closely with the CGM group over the last 7 to 8 months to develop the platform exactly like we had envisioned it. SAM is a database overlay then that our county is going to use in two ways. One, to develop a referral system that is quick, efficient, and confidential, and two, to pull data from a variety of databases and electronic health records so that we can access health status of the people of our county. And understanding what services are being provided, as well as understanding what services there's a gap in. We have this vision that there is no wrong door. The idea being that the concept is that any person accessing services from any agency should be screened with a SAM survey. If a need is determined within a domain, that corresponding agency connected to that specific domain will be immediately notified via email. The notified agency will then have between 24 and 48 hours, depending upon the level of need, to respond to that person and then develop a plan of action. If for some reason the person remains in the red, which would be in a crisis type situation, ideally this person would be targeted at the monthly team meeting so that all providers can weigh in on how best to support this person. So this is really where the hot spotting that Stephen talked about comes in. This is really hard to see. I took a picture of the screen, but this is basically what the SAM referral portal looks like. So when you log into the community portal, you will see this screen. And in the dashboard is the domain of health survey, which is right here. And you'll see specific questions related to the 14 different domains. So housing, transportation, food security, security, financial security, medications, disability, spirituality, etc. So here's some examples of two questions on the domain. Housing. Is housing stable, adequate, and affordable? The first question under that heading, adequate and stable housing is affordable, stable, safe, and adequate for the client's needs. Substantial rental home living with family or friends facing eviction. Client lives in a substandard housing or non-stable housing situation. And then the third one, homeless. Family or individual living in a camper tent or other non-permanent habitat. On the SAM portal, these questions are flagged in red, yellow, or green. Green meaning that there's no action required. Yellow meaning that we should monitor the situation. And red meaning that this person is in crisis within this domain. So the nutrition, adequate knowledge of nutrition and food security, adequate knowledge of nutrition and food security, needs education regarding food stamps, food bank, and general nutrition, or is in a nutritional crisis with no food or means to attain nutritional resources.
We should note that we only have 3 categories and really only 3 things to fill in for each domain, because part of what we were concerned about was time. We wanted the questionnaire to be accessible to people and not take a lot of time to fill out, and so we came at it with just three basic boxes to check under each domain, and so it really is not that big of a time consumer for the person who's trying to fill out the form, because in most cases they've got their own forms and they've got their own evaluations that they're having to do in-house for their own system.
So it takes about a minute and a half to complete the total survey, and we didn't think that, making it as simple as we could, we didn't think that people would object to filling this out. And so I'm sure will be lots of questions about privacy and confidentiality. We have worked with the compliance officer at Gobi to create a universal release for all of the providers that are listed on the survey. And it lists all the partnering agencies on the universal release, and it must be offered before completing the survey. Each agency who might be pinged or emailed, if you will, through the SAM portal will only have access to the information which pertains to their agency and the domains that they are responsible for managing. Agencies will not have access to any other domains who may also be alerted for that same person. So for example, this came up with alcohol and drug, and if people are accessing A&D services, we don't want the transportation agency to be able to see that that person is also accessing mental health or A&D services from us. When a red or a crisis domain is resolved, a new survey will be completed, flipping the red to a green. So getting started, it's pretty easy, really. We require 2 agency contacts with all contact information, including a cell phone number for password reset security. The information is given to the CGM group, and the CGM group adds the agencies to the community portal. They also attach, the agencies decide which domains they want to be responsible for, and so the CGM group gives that information as well and attaches those specific agencies to specific domains. The group then sends a setup email to the agency, which the agency will then log on to and complete for the setup process. Once the setup is complete, the agency can begin administering the domain surveys to those folks interested in signing up to the portal. So currently, we have only about 6 different agencies signed up and approximately 50% of the domains accounted for. Our goal is to complete the setup and January 2015. So our goal is triple aim: better care, better health at a lower cost. And we are hoping that with the use of the software-assisted medicine, we will be able to identify those people that often fall through the gaps. For example, if a person has missed 3 of their medical appointments and we send a letter and receive no response from that person, we are hoping that somewhere along the line, possibly, their car burnt up or whatever, and we'll be able to understand where they're at when transportation is resolved. So we're hoping that this really covers us in terms of access and creates 0% disparity for our people of Wallowa County.
Yeah, the key element of this is that email that goes to the agency so that they can, once that red flag is there, let's say they've identified a transportation issue, then an email goes to Community Connections in this case, which is the transportation program for Medicare and Medicaid clients and just in general in the county. We have no public transportation. Some of you might be able to identify with that. And so transportation is a huge issue. We have people that live 30, 40 miles out at the end of a dirt road someplace at the bottom of a canyon. So transportation is a huge issue. So the idea would be that, that once they get that email, they then will respond to that client and try to resolve the transportation issue. They will turn the green to the red to a green, and we will know that that's been resolved. We recognize one of the things that we are struggling with is how we can keep on top of and monitor the individual clients as we use the system to keep an eye on the changes and make sure that everything's happening the way that it should be. We are participating in a community health worker hub. We have a number of people, quite a few people actually in our county who have been trained as community health workers, and our idea is that probably at some point there will be a community health worker who will be really responsible for kind of monitoring and maintaining what's happening on the SAM network.
We also just received a HRSA network development and planning grant, and so part of this money will probably be put forth towards facilitation of monitoring the SAM, whether it's with the use of a community health worker or the facilitator of the group themselves. But we will have someone keeping an eye on it all the time and making sure that, referring agencies are taking care of the people who sign on and who are in crisis.
And I should say that this is actually merges out of a program that we did earlier. We had a Department of Education grant called the Northeastern Oregon Collaboration for Child Safety, which was a grant which was focused on families where there were alcohol and drug issues within the families, and the children were either at risk for being removed from the family or had been removed from the family, and they were seeking to be reunited with the family. And the original concept of looking at domains, checking the domains, and then making sure that everybody in the community that could help that particular client was helping that client around the domains that they were struggling with, whether it be transportation or housing or parenting skills or whatever. That particular grant created this concept, and that was a successful concept. It worked for us, and so we're taking something that has already been done and has worked, and we're trying to make it a bigger and broader thing within our community. So this is not just a kind of an off the ground, never been done before concept, but it actually emerges from a previous grant project that was proven successful not only in our county but also in 2 other neighboring counties here in Northeast Oregon. So with that particular grant, we did identify the domains. We did contact the agencies that needed to be contacted about the needs of the particular person who was receiving services. This does it far more efficiently and far more quickly, we hope. So at this point, we'd be very interested if there are any questions, any comments, any concerns. We're happy to try to respond.
Great. Well, Stephen and Shante, thank you so much. This sounds like a very wonderful program that can really help to reach out to people who may not have had access to particular issues that would impact their wellness and their health. I think it sounds like it does have a lot of potential, and I'm wondering what will success look like if we talk to you again, let's say in a year, and you've been able to identify people for all of the domains or agencies, and you've been able to enroll patients or clients. What would success look like?
Well, I think success would look like us feeling, well, obviously we're using Sept. Success would look like when red, and we will be trying to keep track of this, when red dots have shown up on the survey, those dots being resolved and moving down to either at least a yellow, but hopefully to a green, which would indicate that they've actually been addressed. So success would look like us changing changing the situation so that everybody that we're working with within the SAM system ends up with basically no reds. I mean, that would be the ideal. Success would also look like the handing off of a person from one program to another in terms of care that they need. Would also look like that happening more quickly and more efficiently. Again, one of the things that we know is that when primary care, for example, refers to us, we used to have a very low percentage of people that would actually show up. You know, they say, go to mental health. You have, you know, we want you to see them for depression, or we want you to see them for your anxiety. And then maybe 20% of the people that they would refer would show up. Then they started sending us the referrals electronically through their medical record system, and we started calling back. That's improved it. This will just make that whole process easier in that particular case. But that same kind of dynamic is present when we talk to somebody about housing needs. You know, your housing is insecure. We think you do a lot better with your anxiety and your depression if you were living in a stable housing situation. Why don't you go to Community Connections? Well, currently we say that, but they're depressed and they're anxious, and the chance that they will go over to Community Connections, take the initiative to make that happen there, you know, is not super great. So again, by us connecting community connections and saying, here's a person who's got this housing need, that Community Connections calls them, they take the initiative to connect with that person and make it happen. So without the SAM system, we think the red dots would stay red, and our hope is that with the SAM system, the red dots turn into yellows and greens, and we will be able to track that using the software.
And I think also success might look like with our high utilizers, the people who access the emergency room 13 times from April to June, as well as 52 calls into the primary health care clinic. Those instances will be reduced significantly, and obviously lowering everyone's cost in terms of serving those folks. I mean, a lot of times, you know, our governor, I think a couple of slides ago, you saw a picture of an air conditioner, and our governor says maybe we can lower healthcare costs if we think way outside the box and provide people with things that they need. There was a patient that he talks about who was accessing the ER almost once or twice a week. And they finally figured out that this person was living in this really hot environment where they were they were literally having like heat stroke on a weekly basis, and so would end up in the ER. Well, a simple solution was they bought an air conditioner for this person, and they never accessed the ER since. We have our own local success stories, such as a person accessing the ER who had recently been fitted with an oxygen
Oh, great. Those are very good examples. We do have a question here from Scott as well, wondering about the unaddressed domains and what are the plans there for the ones that you're still working to find agencies for?
I'm confident that we will actually hook up with those agencies. We just have to decide who's going to do it. One of the domains that sticks in my mind is spirituality, and it's hard because we need someone who's not necessarily biased of the church that they represent, but is more holistic in their spirituality practices as well. And we think we have a couple of folks within the community identified who might be willing to look at this from a very holistic perspective. We're pretty confident, though. We've talked so much about this in the past year that it's really a matter of me finding time in my schedule, them finding time in their schedule, and just making that connection to set them up.
We are a very small community. I mean, we're a very rural community, so we don't have a ton of agencies that we have to coordinate with here. And for the most part, every agency is pretty well defined. We don't have like 3 agencies that do the same thing. We have one agency that does housing, one agency that does transportation, one agency that does parenting, one agency that does, all of the different things that we do. So it's very doable. And so we're not concerned about filling the unaddressed domains. I think the other question, and maybe I misread the question originally, but I was also concerned. One of the things that I've often thought about is what do we do when there has been a red flag emailed to a program and there's no response if the responses aren't happening the way that we want them to. So that's a whole other issue that will be tricky. We haven't run into that yet, but let's say there's a parenting issue and the parenting program, for whatever reason, doesn't get back to that family and get them engaged. What happens there? And then I think an additional issue is going to be what if we identify issues within a person's spectrum? We send the referral, but the client is difficult to get engaged. And I think that's where the community health worker is going to come in. The community health workers that are trained are going to come in. This is going to be an evolving model, I think. And I think at some point there's going to be community health workers attached to the SAM system who will be, so that it'll not just be the email to the referring agencies, but that probably also, ideally, we would be able to connect community health workers to the people who have maybe, let's say, 1 or 2 red flags, and they can help shepherd that person through responding and getting engaged in the care that they need, which is, of course, very much the community health worker hub model. So I think a couple of things are going to come together to make this really effective down the road. So we're excited about how it's going to play out, and realize that it could get richer than even we thought originally.
So is there a place within the actual system where an agency could update that part of the file to say this client or patient has been contacted and awaiting a response? Is there a place for that kind of communication within the SAM system?
Yes, with each with each domain, there's actually a text field within that domain to make specific notes about each domain. And then from there, let's say, again, transportation was in red. So at the end of the survey, it will ask the person giving the survey which provider would you like to select. And sometimes there's more than one provider for a domain. So, for example, medication is handled by the pharmacist as well as the primary care clinic, as well as the mental health clinic. And so if it's mental health, in nature, then the person administering the survey would select that drop down. and then an email goes to that specific agency. You can attach any text that you want to the email as well, and there's an inbox within the portal that you can just email certain providers whenever you need to.
And then once a person has responded to the client, they can mark that within the system and change the color, change the tab within the system so that it's noted that the issue has been resolved.
Oh, great, great. Thanks for explaining that. I just want to remind everyone, if you have questions, you can feel free to type those into that chat box down there. I'm wondering about what the biggest challenges have been for you so far in getting all of this set up.
Well, I can tell you that when you're working over the phone and email and you have this vision of something, trying to translate that to people who write software who have never worked in healthcare can be really challenging. And they've developed their software for medical purposes. So a lot of the disconnect for us is they were thinking very of a medical model, and we are thinking of a very global, very simple model. And so it took us about 8 months to really work out all of the kinks. And there was just some, silly language barriers in terms of what we call things as opposed to what they call things. And, it just took us a while to iron it out.
Well, one of the issues was they wanted to be able to measure changes. So we wanted red, yellow, green, and they wanted a number. They wanted 3, 2, 1 so that they could say, well, this person had a score of, the 17 domains, they had an average of a 2, and after they participated in the program, that the raw number went down because the 3s became 2s, the 2s became 1s, everything went down. They wanted the number, and for some reason that was a problem. And we finally just said, fine, put a number in the middle of the color. We don't care. But it was little things like that actually were the biggest problems. And I think the other thing was just the whole concern over confidentiality has really been a big barrier. We've really had to work through developing the whole confidentiality release of information portion of this so that everybody's comfortable in participating. And we had to set it up so that only, so that information that was not problematic was not getting to people who shouldn't get it. Or information that was problematic wasn't getting to people who shouldn't get it.
Right, right. Well, what kinds of advice would you have for communities who are trying to accomplish something similar or who are interested in reducing disparities in health in their communities?
Well, I think it's really important to start at the local accessor level, meaning I think one of the greatest meetings that we ever had was that initial local community advisory council meeting. There was about 30 plus people at that town hall meeting who were actively participating in trying to tell us what Wallowa County did well and what they could use improvement on. And I think from there, we gained a whole lot of information and understanding about how this project should be driven. The other is that, if you are in a pilot program, which Gobi has offered to us through use of SAM, that you understand what your project is versus what the, piloting company's project is. And we kind of had two different projects trying to get at some of the same numbers that Stephen was speaking about, and there were some barriers there. So really good, clear communication. We had the SAM group actually come out to our county and visit us about 3 months ago. When they did that and had eyes on all the different agencies that we took them to, they really got a great understanding what we were asking of them. And we all were laughing, thinking, gosh, we should have done this 10 months ago. We should have started with them visiting the county so that they could really understand what it was that we were asking of them, and just how small our county was. I mean, I don't think that they had any idea about that. And so that really helped speed things up.
I think the other thing that's important is to recognize that all the domains are important and that all the partners are important. I think there's a tendency sometimes for certain players within the system to have a lot more power and weight than others, and so for the medical providers or for the mental health providers who are, you know, quote unquote professionals and all of that kind of stuff, for them to be willing to really respect and listen to and value the things that the other providers offer is really a critical component. We're really lucky here because our providers do get it, but I could see that being a problem in some areas. I see a question about funding. Currently, this is being funded. It is a pilot project, and so it is being funded by GOBI, which is a mental health organization, which is one of the partners in Eastern Oregon Coordinated Care Organization. So it's kind of a grant funded thing at this point. My belief is that there's going to be long-term support from GOBI for this, and it may actually get moved to other counties within the GOBI system. But that's a fair question. We believe that if we do the right job and we can show results, that our coordinated care organization will say that's valuable enough, it's saving us enough money that we're willing to put money into it and keep it going, because it's keeping people out of the hospital, it's keeping people out of the ER, it's getting people to their medical appointments. One of the things that you might have noticed was the benchmarks. So the state of Oregon has, well, the CCOs have like 17 benchmarks that they are required to measure, and they are required to meet. There's criteria that are required to meet in order to get paybacks from the system. So if they meet the benchmarks, they get money back, and if they don't meet the benchmarks, they don't get money back, and that's millions of dollars. And so if we can show that benchmarks are being met, so for example, if keeping somebody's diabetes under control is one of the benchmarks, and we're looking to have a percentage of patients with properly controlled diabetes, managed diabetes, if we can show that by paying attention to transportation, paying attention to food security, paying attention to those kinds of things, helps people stay in the appropriate range in terms of their blood sugar levels, then that's valuable to the system, and then it is our belief that the system will fund that.
We were able to get a commitment out of GOBI for 5+ years for this pilot. One of the concerns from the providers who meet monthly was that we were going to train people on how to use it, and then they were going to abandon it after a year or 2 years. So we did get a relatively long-term commitment from GOBI that we would continue to do this and they would sustain it.
So are there any incentives that will be given to people in primary care to continue using the SAM system?
Well, I think the primary incentive is the one that comes from the CCOs itself, which is that if you don't meet the benchmarks, you don't get money. You don't get this money back. So this last year, I think our CCO met 13 out of 17 out of 13 of the 13 out of the 17 benchmarks. So they got money back, but they didn't get as much money back as they would have if we had met all the benchmarks. So it is our belief that a system like this can help counties meet those benchmarks, and if we can show that, then I think that's going to be incentive, because that money comes back to the providers if they meet the benchmarks.
Mm-hmm. Okay. Well, are there any other questions from our participants today, our audience? Well, I don't see any, so Stephen and Shantae, I just want to thank you again for sharing your work with us. I hope that the program goes very well, and I look forward to hearing updates about it.
Sure. Thank you for having us. It was a pleasure.